طيب أوكي، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. Welcome to the fourth day of the Bootcamp for the Board Review Pediatric GI Fellowship. And I'm very happy and glad to present the speaker for this lecture, Dr. Iyad Al-Hidafi. He is a pediatric gastroenterology consultant, and he is also an IBD specialist. He works as a consultant in خميس مشيط Children's Hospital. أنا طلعت شوية على البرزنتيشن. رائع، مرة رائع ومفيد و MCQs to the point. فأول شيء شكرا دكتور إياد، ألف عافية. You have unlimited time. Take your time. تفضل.
طيب بسم الله الرحمن الرحيم. أول شيء I would like to thank Dr. Mohanad for inviting me and giving me this opportunity to share with you uh, you soon who become our colleague in the field. I wish you all the best. I tried to make it interactive, so I hope all of you try. It's just an anonymous participants. Those who wish to register their name, they are welcome. So I have looked to the latest Saudi Council Pediatric Gastroenterology and Nutrition Blueprint, and you can see that there is some shift to what it used to be before. Now they have more percentage in small bowel and colon, one third. Also, you can domains like nutrition, those who present with growth failure, anemia, find it in pediatric GI emergencies, like those who present with acute severe ulcerative colitis or toxic megacolon. Also, you can find it in those who present with colectomy or pediatric complication, like surgical complication, like stricturing, penetrating, etc. So IBD per se, it has a high percentage in the written exam, but one of my purpose of this presentation is also prepare you guys for your daily, everyday practical. I hope it would be of benefit, inshallah, in your practice as well. So the objective of my talk, I just want to minimize the screen. Sorry, I cannot see my screen now. Yeah, now it's better. So the objective of the talk is to understand the classification and epidemiology of pediatric IBD, to interpret the diagnostic workup, apply disease activity and severity tool, to be familiar with the concepts of risk stratification, to review the therapeutic strategies like conventional treatment or even biologic and advanced biologic therapies. Also, we should be familiar with the new concept in IBD world, like positioning and sequencing advanced therapies and disease monitoring. There is a missing slide, so I'm not sure why it's not presented here. Can you see anything? I cannot see my...
لا ما أشوف، بس يمكن تسويها يعني شيل المود.
أشغل التسجيل برا ما يا أخي ما تنقلب بين أوف 1 لا F6.
طيب
شيل أيوة الآن واضح، بس إذا
طيب.
اللي بعدها شوف اللي بعدها روح.
I don't know why. So, yeah, can you see now?
إحنا شايفين هذه السلايد، شوف اللي بعدها. أيوة خلاص.
طيب This is just to make sure you guys have all signed in to the Slido. Just let us know from where you are joining us today. And I don't know what was the number yesterday or the day before of the total attendee.
كان رينجينج يعني 50 60 زي كذا.
Okay, because we are only now 12. Should we proceed? Okay, we have fellows from all over the country, mashallah. So let's go on. 27 have registered already. I hope now more and more is registering. And before we proceed with the IBD bootcamp, let's take some survey so you can assess yourself after. So how confident are you in recognizing pediatric IBD at presentation? So most of you are like having moderate confidence in recognizing those patients. How well do you understand IBD classification system? Have you ever heard about Barry's classification, revised board or Montreal? So we have like yeah, for the most part, it's moderate. So most of you have heard about the IBD classification. So how comfortable are you with initiating and monitoring biologic therapy in children? So there is like a rate between very confident and a little bit not confident. So how well do you understand the role of proactive and reactive TDM in IBD? Have you ever heard about it? Are you familiar with it? Are you using proactive TDM or reactive TDM? So usually the participant is 30, so we will wait for the 30. Okay. So this is the first question, but before going to the first question, allow me to go back because I have made some ground rules. I don't know why it's not showing here. Now you can see it.
احنا نشوف your
Okay.
ما هو البرزنتيشن مود، ما نشوف
So
البرزنتيشن. ايوه
this
كذا
is
تمام.
this is the ground rules for the session. I want you to be interactive. There is no judgment here. It's just to assess yourself and to learn from your mistake. I have attached some camera emoji. So it's a hint for you to take a screenshot. That means it's important either in your practice or for your to keep it in your pocket. We might not have enough time to go through those important slides, but at least take a screenshot of it. I try to make my question as a real scenarios and practical points. It could be useful in exam and practical daily practice. We are trying to stay on schedule. We don't have much time, and IBD is a big topic. So I guess there is no live chat question during the slides, but feel free to reach out to me afterward. I will share my contact info. And I guess Dr. Mohamed mentioned that there will be a recording. I tried to be aligned with the Saudi Council for Health pattern. There is no true or false or accept questions. I tried as much as I can. So let's enjoy the ride, inshallah. So the first question, which of the following statements best reflect the epidemiology pattern of IBD in pediatric population compared to adults? UC is the most common pediatric IBD subtype. Crohn's disease and UC occur equally in children and adults. Crohn's disease is more common than UC in children, unlike adults. IBD unclassified is the most common form of IBD in children, or Crohn's disease is rare in children and typically present after age 18. So time is up, and most of you have got it right. Yeah. So Crohn's disease is more common than you see in children, unlike adults. In pediatric IBD, Crohn's disease predominant. It can reach 60 to 65, compared to UC, which can reach to 1/3 of the IBD population. In adult, UC is more common and occur at similar frequency to Crohn's disease. IBD unclassified is more frequent in children than adults, but it's not the most common form. The ECOS begin highlights that the higher prevalence of Crohn in children reflect the aggressive and extensive phenotype at presentation in pediatric IBD. That's why in most of the adult studies, they made the age of onset as a risk factor or risk stratification. So question 2, which of the following statements regarding the role of serology testing in pediatric IBD is most accurate? Positive ASCA definitely confirm Crohn. Negative ANCA rule out UC. ASCA and ANCA are recommended as first-line diagnostic tests. Serology marker cannot exclude the diagnosis of UC or Crohn disease. Again, mashallah, you got it right. So serology marker cannot exclude the diagnosis. So according to the revised Porto, no serological pattern, including ASCA or BANCA, is definitive. While positive ASCA and negative ANCA is more common in Crohn's, and the vice versa, positive BANCA positivity in UC, these are not sufficient alone to confirm or exclude the diagnosis. So you can have patients with Crohn who have positive BANCA and negative ASCA. Actually, if you see the antibodies that related to IBD, ASCA is more prevalent in Crohn's disease. It can reach up to 70%, while BANCA is more prevalent in UC. But if you have like if you are working or you have witnessed a more expanded antibodies, might be familiar with pre-protease antibodies. It's usually done by rheumatology if they suspect granulomatous disease, BANCA-associated colitis, those who present with uh, like sarcoidosis or Wegener granulomatosis, but sometimes they can present with colitis. So we have witnessed that it can present also in IBD, but more evident in primary sclerosing cholangitis. It can reach up to 70%. The last two, it's not that important. But for the practical points, serological inflammatory marker testing may help differentiate Crohn's disease from UC in cases of unclassified IBD and support diagnosis of IBD in atypical cases. So we usually do it in tricky cases, confused like IBDU cases. Routine serological testing is not recommended to diagnose of Crohn's disease or UC, so it's not like a first tier blood work that we or use. Serological marker can be used as an adjunct to diagnosis and useful for prognosis. For example, and this is very important information, if you find if you happen to diagnose a patient with Crohn's disease and he has a high ASCA, you can anticipate or predict that he might develop structuring disease. So it's one of the important risk stratification as well. So next question. Which of the following statement about lab testing in mild IBD in children is most accurate? So it's mild IBD. CRB and ESR are almost always elevated in mild Crohn. Normal hemoglobin and albumin exclude inflammatory bowel disease. Over 50% of children with mild UC may have normal CRB, ESR, and albumin. If CAL is not helpful, if CBC and CRB are normal. So, mashallah. So far, so good. So over 50% of children with mild UC may have normal CRB, ESR, and albumin, and this is very crucial information. Some of us might encounter a patient or referral, and you might think in your you might think that if the CRB and ESR is normal, it's not IBD. This is wrong. Mild IBD can present with normal labs, reaching up to 50% in UC and 20% in mild Crohn. So the message here, normal blood work does not rule out IBD. And here, just to clarify the differences in ESR and CRB, the pitfall of ESR, it's not specific. It can be affected by anemia because it's acid ESR is from the name erythema sedimentation rate, so it has to do with blood. It's also affected by age. Also, one pitfall of the ESR, it slowly rise and fall. It doesn't reflect acute sitting or acute relapse. So even though it's one of the blood work that was included in the Pediatric Crohn Disease Activity Index, I find that CRB is more accurate and more clinically relevant to the patient. So if you ask me per se, I prefer CRB, but usually we order them both. And if you read the new Pediatric Crohn Disease Activity Index, it's called the weighted Pediatric Crohn Disease Activity Index. It's more useful because the previous one was lengthy, and they have eliminated the ESR from the new one. So next question, which of the following statement is true regarding fecal calprotectin in pediatric practice? It can accurately distinguish Crohn disease from UC. Mildly elevated level are highly specific for IBD. It is the best marker to determine small versus large bowel inflammation. It may be elevated in healthy infants or children with celiac disease. So you are on fire, guys, mashallah. It may be elevated in healthy infants or children with celiac disease. If CAL is sensitive for detecting inflammation but not specific for IBD. It can be seen with celiac, allergic enteropathy, infants. So you cannot distinguish between the IBD subtypes by the disease location. And almost 400 IBD patients with 300 control. And the result, they showed that sensitivity was high, reaching 97%. So it's a very sensitive test, and it's not that very specific. So if you have a normal child with normal fecal calprotectin, that you can uh, 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 be more confident that it's not IBD positive. It doesn't specifically or something else like infectious colitis, etc. So if CAL is more accurate in discriminating IBD from other GI or systemic inflammatory condition, however, it cannot differentiate IBD from infection, from non-steroidal use. It cannot differentiate Crohn from UC. It cannot differentiate small from large bowel involvement. So if you were to ask what is the best single test before proceeding to imaging or endoscopy, that will tell you, give you an answer. I would choose fecal calpro for sure. So the practical points: normal blood tests do not exclude IBD. Many children with mild disease can have normal lab at diagnosis. A significant number of children with mild IBD may have normal hemoglobin, albumin, CRP, and ESR. However, if you find low serum albumin, it might reflect disease activity and protein losing into enteropathy. And in a lot of guideline, it is one of the risk stratification. Fecal marker like calprotectin or lactoferrin, it is high sensitive but not specific. And as I told you, if cal is more sensitive than CRP or ESR in neonatal IBD. So this is to sum up. If you happen to have a patient with chronic abdominal pain and diarrhea, take history and complete the assessment. Now you have if it's taken alone. If you add to that adding video, so both calprotectin will make you you will now proceed for the endoscopy. So next question. 12-year-old boy is inflammatory bowel disease. He has undergone ileocolonoscopy and EGD with multiple biopsy, which confirmed diagnosis of classic UC with continuous colitis and no GI or ileal involvement. The team is considering whether small bowel imaging is necessary. What will be your response? Perform magnetic resonance enterography in all suspected IBD cases, including confirmed UC. Perform RE only if the child developed perianal disease or small bowel as you have data, or proceed to the wireless capsule endoscopy to rule out isolated small bowel Crohn's. Extra 10
دكتور
دقيقة.
إياد يقطع شوية شكل الصوت عندك.
تسمعوني الحين؟ أنا حتى السلايد معلق.
أتوقع مشكلة بالنت يعني يمكن، بس الآن أنا أسمعك، بس الشباب يقولوا يقطع الصوت شوي.
طيب خليني أشبك اللابتوب على الجوال، ممكن أحسن.
الآن واضح، يمكن إذا تبغى تكمل، إذا كان هذا الآن واضح
طيب
ماشي الأمور.
إذا في شيء خبروني. طيب let's get the answer. Okay, most of you have chose the any suspected IBD to perform. أنا ما أدري ليش الشاشة صغرت. So most of you have chose the first choice, and we will come to that. So the correct answer is C, omit small bowel imaging as the diagnosis of UC is already confirmed. So MRE is the preferred small bowel imaging modality in suspected Crohn's disease and IBDU, but not classic or typical UC. However, small bowel imaging can be omitted in children with a clear diagnosis of typical UC based on classic endoscopy and pathologic confirmation from CGD. The wireless capsule endoscopy is reserved for inconclusive cases or if MRE is not feasible. So this is the latest consensus on the small bowel imaging in pediatric IBD, the ECO-SPIGAN. MRE is the preferred imaging at diagnosis in pediatric IBD due to high accuracy and no radiation. It detects small bowel involvement and complications like fistula, abscesses, and stricture. The wireless capsule endoscopy is a second-line option when MRE is not feasible or non-diagnostic, but should follow a patency testing, the patency bill, to reduce retention risk. Ultrasound is a valuable initial screening tool, and nowadays it has been a hot topic in the pediatric in the IBD world because it's like a point of care that you can do in your clinic if you master it and if you are good at it. There will be a good it will be a good tool in your hand. Use of contrast, small intestinal contrast ultrasound improve its accuracy. Small bowel imaging is essential in suspected Crohn's disease, IBDU, or atypical UC. So these are the indication of proceeding for small bowel imaging like MRE or wireless capsule endoscopy if you suspect Crohn's disease, or if you have atypical UC or IBDU. That's when you go for the MRE. Is my sound clear, or should I try to connect in? Because I cannot see the chat. Is it clear now? طيب. An eye is being evaluated for intermittent abdominal pain and poor appetite. Lab show normal CRP and ESR. Fecal calprotectin is bending. Abdominal ultrasound shows terminal ileum wall thickness of 3.2, but no increased Doppler signal, preserved wall stratification, and normal peristalsis. Which of the following is the most appropriate interpretation? Diagnostic of Crohn's disease and require immediate initiation of therapy, high specific for UC, of the T, normal correlation.
الصوت مو واضح دكتور إياد.
طيب تسمحوا لي أغير الواي فاي الكونكشن؟
إلا بالله دكتور رياض، لأنه صراحة الموضوع جميل وكذا، بس المشكلة الصوت بيقطع كثير
طيب
ننتظرك.
I'll stop sharing، اسمحوا لي. Can you hear me now?
ايه نعم.
إن شاء الله إنه الحين أحسن. طيب هذا السؤال مرة ثانية if you أتوقع وصلنا هنا. We can wait for people to answer. It's the same question. Yeah, so most of you have got it right. So the idea and message of this question is how to interpretate ultrasound or incomplete finding of ultrasound. We might have many consultation because of just an abnormal bowel thickening, but it's a matter of when to take it seriously or when to just omit it. So most of you have got it right. It's suggestive, but not specific. So the wall thickness alone in the TI is not specific for Crohn's disease without additional feature like hybremia, loss of stratification, or decreased motility. The finding is incomplete. This is what we call the mural finding. Echo notes that isolated thickening is sensitive but not diagnostic. Clinical correlation with symptoms, fecal calprotectin, and possibly further imaging is required. So I've made this summary of the mural and extramural. You can find the extramural in your right. So extra means outside the bowel wall. And if you go to the second column, you can see it's things that is it's located outside the gut, like mesentery, lymph node, and fat. But if you go to the left column, it's the mural finding. And the first one is the wall thickening. Actually, we don't have pediatric validated numbers so far. This is adapted from adult. And there is ongoing study to determine what is the appropriate cutoff of pediatric age group. Uh, uh, in our practice, anything above 3.5, either in the colon or TI, it's considered abnormal. If you find altered echogenicity, loss of stratification, increased color Doppler like hybremia, which indicate active inflammation, reduce or absent peristalsis, which indicates stiffness of or transmural inflammation, along with the extramural finding in your right, like creeping fat, which is a sign of chronic Crohn's disease, enlarged mesenteric lymph node, or fat rubbing. Now, if you have most of these finding, you can suggest it's more and more of IBD, and you have to correlate it with other. So, next question. A 10-year-old boy with suspected small bowel Crohn's disease presents for further investigation after an incomplete colonoscopy. The team is considering a wireless capsule to assess for mucosal lesion in the small bowel. Which of the following is recognized limitation of the capsule? Inability to detect mucosal inflammation, poor sensitivity compared to MRE, risk of capsule retention, contraindicated in children older than 1 year, require sedation for all patients. So this is an easy one, I hope. Yeah, 100%. So yeah, we know that capsule retention is a known risk for the wireless capsule endoscopy, which might yeah, having this complication might expose the patient to surgery, and you don't want that. So the way to go is you have to do the patency bill and if it's normal, you can safely proceed for the capsule endoscopy. In terms of sensitivity, it's highly sensitive. However, it doesn't detect the deep complication like fistula or stricture, like the MRE. And one of the choices was contraindicated in children above 1 year, which is not. So next one, 15-year-old boy with non-IBD undergoing reassessment. Biopsy showed crypt distortion, basal plasmacytosis, and scattered crypt abscesses. Which histological term best apply to this pattern? Inactive chronic colitis, focal active colitis, or indeterminate colitis? So you have some keywords. So 2/3 have got it right. So you are right, the active chronic colitis, and I find that knowing the histology, the IBD terms of terms that is like a keyword in histology, it's very important in our practice. We should be familiar with it. So active chronic colitis is defined as chronic inflammatory changes along with superimposed acute inflammation. And we can see this pattern in active IBD flares. So I wrote some slides, I find it a very important topic, so we will spend some time in histology. So before going to abnormal mucosa or abnormal colonic histopathology, we should be familiar with normal. And if you look at the colonic biopsy, we can see it's from in out. It starts with the mucosa, so you can see the epithelium that is lying down the lamina propria, and they lying down on the muscularis mucosa. This is what we see in the biopsy. And if it's extend beyond the muscularis mucosa, this is when we see the ulcers or in the biopsy. So this is what is normally the normal biopsy, the normal colonic biopsy looks like. If you have, if you see the star shape, it represents the normal mucosa, the muscular. I'm sorry. It represents the normal muscularis mucosa. And if you have normally aligned adjacent to each other with normal architecture, this is a normal crypt. And usually if you see a pivot crypt as denoted in the arrow in the right side, yeah, here, if you find it occasionally, this is normal, but if you find it a lot in a slide, this is abnormal. So the normal, it should be two adjacent crypts that's reaching the muscularis mucosa. If you find it shorten, this is atrophy, and it is abnormal. Yeah. So I want you to be familiar also with two important concepts that might be confusing for us, is chronicity or chronic inflammation. Sometimes when they reported when you see the histopath reports, you will find a lot of term, chronicity, chronic inflammation, active inflammation. So we should be familiar with that. And when we say chronicity, it's a structural concept. It's when we talk about the crypt distortion like irregular or branch or shortened crypt atrophy. But if we talk about the chronic inflammation, it's a cellular concept. It's mean increased number of lymphocyte and plasma cell, and the most important cell that indicate abnormality, it's basal plasma cytosis. It's a keyword that indicates an early or de novo IBD. It's one of the strongest predictor of an IBD diagnosis, uh, and it can resolve fully or persist. So this is when we come to the abnormal histology. As you can see here, the crypt now, it's not adjacent, it doesn't look nice, some are shortened, it doesn't reach to the muscularis mucosa, some are bifid, abnormally shaped. So there is some element of chronicity here. And if you can see the star, this is what we call the basal, because it's in the basal side of the mucosa. This is a basal plasmacytosis. It's represented here by the star. And yeah, you can take a picture of this slide because it's very important, and it has a nice explanation of the slide. So lastly, acute inflammation. We have two important terms, cryptitis or crypt abscesses or ulcer. So cryptitis is the presence of at least one neutrophil in the crypt epithelium, while crypt abscess is the presence of neutrophil in the lumen, and ulcer, as we said, is its extension to muscularis mucosa. So if you can see the arrow, it represents the crypt abscesses because it's in the lumen. While the circle, you can see there is the crypts now, it's abnormal, and this is the start of formulation of the granuloma. So in summary, crypt distortion and basal plasmacytosis are hallmark sign for chronic inflammation in IBD. These findings support diagnosis of IBD even in the absence of granuloma or active inflammation. So if you find chronic crypt distortion, this is a chronicity and chronic mucosal injury. So it's a diagnostic, but it doesn't indicate disease activity. Basal plasmacytosis, it's, as we said, one of the important marker, and it's an early IBD marker, and it's a diagnostic for sure, but it doesn't indicate activity. Cryptitis and abscesses, however, it indicates active inflammation, but it doesn't support the diagnosis. So if you find it in newly diagnosed IBD, you did the scope and biopsy showed only cryptitis and crypt abscesses, you can't say it's IBD. So next question. In contrast to disease activity, disease severity in pediatric IBD refer to overall disease burden, including complication and long-term impact, depth of mucosal ulceration at colonoscopy, Bucci or pediatric Crohn disease activity index score at diagnosis only, the degree of neutrophilic infiltration in the mucosa. So you are right. So overall disease burden, including complication and long-term impact. And the idea of this question is to differentiate between two different aspects in IBD terminology, which is disease severity and disease activity. Activity, it's like a snapshot. It's like when you assist the patient at the clinic and you apply one of the score, either the clinical score or endoscopic score or histology score, whatever. But disease severity is cumulative and holistic. It means that you will review the patient past history, if he had any complication, any colectomy, any previous surgery, any growth failure, any previous biologic use or biologic failure. This is the importance of differentiating between these two. And again, activity reflect cross-sectional assessment of symptom, sign, endoscopy, histology, and biomarker. And you can ask about it, just for example, how is your patient today? While severity is longitudinal disease course and historical factor that provide a more complete picture of the prognosis and overall burden of the disease. So we cannot go through all of the activity index, but I know it's very important. So I just find this eco web page. And what I find important for you, because there is a lot of score that both for pediatric and adult, but these are the one for pediatric that I find it useful and find it in handy, and it's important to have. So if you can scan it and focus on the clinical and endoscopic score. And again, symptom can just present the tip of the iceberg, but what's beneath the iceberg is an ongoing intestinal damage. And if you can see here, there is, it's like a roller coaster of relapse and remission, but the blue shaded area, it showed that there is an ongoing activity of the disease. So the relapse and remission, it represents that when you see the patient or when he come to the ER, this is the time when you assess his activity. But disease severity is what's represented here as the blue line. And now the new IBD approaches, you might notice that there is a concept of upfront biologic use or risk stratification, because we come to understand more and more that if you catch the patient before the complication, you can for sure prevent progressing of the disease. So I hope we got this concept right. So next question. This is a tricky one. A 13-year-old girl was diagnosed with Crohn's disease at age of 9. Her disease involved TI, ascending colon, and duodenum. Imaging also showed penetrating with a fistula and stricture in the ileum. She had growth failure prior to diagnosis, but has since cut up growth. According to Barry's classification, which of the following phenotype label is most accurate? So not to confuse you more, I won't read it. So there is a debate between B and C. Yeah, but this is good. So the only difference between B and C is the B2, B3, which means penetrating and structuring. And those who chose C are right, because in the vignettes we can see he mentioned fistula and stricture in the ileum. So the idea of this question, I don't expect you to memorize the Barry's classification by heart, but at least know it's important, because it's one of the causes of choosing upfront anti-TNF or just go with the conventional therapy. So the correct answer is C. So the A, before going to that, we know that the IBD classification, it has, maybe you have heard about Montreal and Paris. So Montreal is for adult. It was done, I guess, in 2005, and Paris was in 2011. It was modified to fit the pediatric age group. We have added the G, which represent the growth. It wasn't mentioned in Montreal, so this is a modification. They also have modified the age because Montreal is A was below 17, but we have changed it to A1, which is less than 10, or AB, which is more than 10, and we will know why we chose 10 as a cutoff. Also, one of the modification is combining both B2 and B3. Montreal, it has B1, B2, or B3. In Paris, this is a new modification. B2 and B3 can be together. So you can take a screenshot for the IBD classification just to be familiar with it, because there is Porto, there is Paris, there is Montreal, and the difference between Porto and Paris. Porto is for those who are suspected IBD, not diagnosed. You are still suspecting, and if you read the revised Porto, it's very nice. It will tell you how to approach those patients, and most of our question today was adapted from the revised Porto. The Paris and Montreal, it's for the phenotype to know who's at risk of bad disease or worse prognosis, or who are those with mild disease that you can go with the conventional. So again, this is what we explained before, the main differences between Montreal and Paris. And you can just take a capture screen. As we say, the age, they have changed it to less than 10 and more than 10. Location, they have expanded the L4. It was isolated upper in the Montreal, while in Paris, they have divided it's to upper disease proximal to ligament of traits, and lower and upper disease distal to ligament of traits. Also, one of the differences is the B2, B3. It's combined together. And the perianal disease, it's the same, but we have added the growth as a domain in the classification. So why 9? Why they chose 9 years? It was for a different reason. First one, because of the phenotypic variation by age. Children diagnosed less than 9 tend to have colonic predominant Crohn, like isolated colitis. If you have very early onset IBD, we know they tend to have colitis more than ileocolonic Crohn disease. Children diagnosed more than 9 are more likely to have ileal disease. So the age threshold capture a biologically relevant shift in disease location. So first notice they have capture is the location. The second thing they have noticed that the NOD2 association, the colitis predominant Crohn disease, more common in less than 9, as we said before, seen especially in children without NOD mutation. Ileal Crohn, more common in older children, and they have noticed that it's associated with NOD2 variant. Also, they have noticed that there is serologic maturation, like ASCA positivity increase after age 8, and stabilize between 10 and 15, supporting a maturation of immune response that align with this age cutoff. Lastly, UC severity by age. In ulcerative colitis, children diagnosed more than 9 years are at higher risk for biologic therapy or colectomy, while those who are less than 8 years, it's only 7% need to escalation of therapy. So it's statistically significant age cutoff, the 9 years for treatment escalation risk. So this is why they chose the A1 and A1A and A1B. So I hope we get through this confusing concept. So the next one, according to the Paris classification, which of the following statements best reflect the relation between age at onset and Crohn's disease phenotype? Structuring and penetrating behavior are more common in children diagnosed after age 10. The presence of perianal disease significantly decreases with younger age of onset. Disease behavior and perianal involvement are relatively independent of age at diagnosis. Colonic involvement is more common in older children due to delayed node expression. Disease behavior vary by age, only in the presence of node 2 mutation. Some of those concepts we have already discussed previously. So yeah, but there is like it's yeah, I know it's a tricky slide. It's a tricky the Paris classification. It's hard to comprehend, but I hope we at least give you a hint why they chose those things. So disease behavior and perianal involvement are relatively independent of age at diagnosis. So it's not acting like the location. The location can be affected by age, but the disease behavior it doesn't affected by age. Yeah, while disease location clearly varies by age, like colonic disease is more common in those diagnosed less than 10, the behavioral subtype, namely, so B1 is inflammatory, 90%, B2 is structuring, B3 is penetrating, B2 and B3 both structuring and penetrating, and the presence of perianal disease modifier, it doesn't affect it by age. So this is the message of this question, and this is the message of the age. You should know by now that age can affect the location, but it doesn't affect or it doesn't has to do with the behavior of the disease. So again, when evaluating a child who is newly diagnosed Crohn, do consider age to help predict location, like colitis in those less than 10, ileal or ileocolonic in more than 10, but do not assume that younger or older age predicts more or less severe behavior or presence of perianal disease. Again, this is the extension of Paris. They also have included the UC with some modification. For example, they have expanded the extent. Instead of E1, 2, or 3, they have added E4, which is pancolitis. And in terms of severity, they have shortened it to never severe or ever severe. So practical point again in disease location and behavior, but now in pediatric UC. Extent is defined by macroscopic appearance. It doesn't, when we say extent of the disease, it's when you do the scope, you don't have to wait for the histology or imaging. Pediatric UC often present with extensive or pancolitis. Extensive is E3 and pancolitis is E4. More extensive disease is associated with higher colectomy risk, especially in adult. And if we know this, if we have high bucci at admission, we predict increased risk of colectomy and need for second-line therapy. So next question, which of the following best characterize infantile onset IBD, diagnosed under 2 years? It's typically mild and respond well to standard immune suppressive therapy. It is rarely associated with family history of IBD in first degree relative. It's often linked to monogenic mutation. It presents with disease behavior and genetics similar to adolescent onset Crohn. It should be classified as ulcerative colitis unless proven otherwise. Yeah, most of you got it right. So it's often linked to monogenic mutation like interleukin 10 or interleukin 10 receptor signaling. Infantile IBD less than 2 years is more severe and treatment resistant, and we know for a fact that those with early onset IBD are very tricky and very refractory and has different pharmacokinetic in terms of using the biologic, and now they are studying if they might require more intensified doses. It shows high familial clustering. 44% with first degree family history represent the severe end of the IBD spectrum. So here's mnemonic for how to recognize monogenic IBD. So in the right side, it has to do with testing and labs, and in the left side, it has to do with your clinical assessment. So of course, if there is a family history, you should suspect it as there is like 40% risk. Age at diagnosis, we know as a definition, very early onset is those who are less than 6, and infantile less than 2, and neonatal less than 28 days. Also, which when we talk about microscopy, if you find abnormal histological reporting like apoptosis, that indicates something is off and you should suspect a monogenic disease. It also has been linked to immunodeficiency, like if you have a child with recurrent sinopulmonary infection or delayed cord separation or abnormal organism, you should suspect it, or even cytopenia, and you should order the baseline immunological workup like immunoglobulin and etc. In terms of location, yeah, they can present with perianal disease. They can present as upper GI IBD. So location also is it can give you a suspicion. And as a fact, we know for sure the younger the severe disease. In the right side, the microbiome, they have noticed that microbiome have been associated or dysbiosis have been associated with monogenic IBD, and they anticipate it might be the cause for IBD. The autoimmunity sign, like if you have IBEX or FOX3, you can anticipate this is a monogenic IBD. Testing, yeah, they worth testing. They worth sending a whole exome, sequencing, or targeted panel to rule out IBD. And they said in one consensus, anyone below 2 and you suspect IBD, you should screen him or test him. But if he's less than 6, if there is like many red flag, you can proceed for the testing. In terms of management, yeah, once we reach a diagnosis, yeah, some might require special treatment for this issue. The extraintestinal feature like alopecia, dermatitis, it can raise the suspicion of monogenic IBD. And again, it's a refractory and hard to treat disease, and it has also a severe perianal disease. So I chose not to present many slides because I find this summarizing most of the very early onset IBD. And you can take a screenshot for that. It's a red flag or alarming sign when to suspect primary immunodeficiency. So next question. During colonoscopy of 13-year-old girl with non-pancreatitis, the terminal ileum show a short segment of mild non-structuring erythema. Cecum is inflamed and biopsies show no granuloma. Which of the following ileal finding would be incompatible with backwash ileitis and should raise concern for Crohn's disease? Mild non-structuring erythema in the TI with inflamed cecum, linear ulceration in the TI with anormal cecum, inflammation of the TI in a patient with BSC and pancreatitis, TI inflammation resolving after colectomy, histologic absence of granuloma in ileal biopsy. So half of you have got it right. Yeah, and it's a tricky topic to differentiate between backwash ileitis and Crohn's disease. But the idea is if you have worse TI disease than cecum, this is Crohn's. Backwash ileitis, the cecum should be worse than the TI. So those who chose C, it should be, I'm sorry, it should be B, but here it's C. Linear ulceration in the TI with normal cecum. This is Crohn's, not backwash ileitis. So linear ulceration in the TI with a normal cecum, backwash ileitis occur in up to 20% of patients with colitis. It's due to reflux of colonic contents into the TI via an incompetent ileocecal valve. Backwash ileitis is part of the typical UC phenotype when seen in pancolitis. So it's not Crohn's, it's not atypical UC, it's not IBDU. It is more frequent in patients with BSC, and this is very important information, and we will come to that. If you find granuloma, lineal ulcer, ileal stricture, these are all pointing towards Crohn's with normal cecum. For sure, this is Crohn's. Submucosal inflammation or crypt architectural abnormality or atrophy are not typical of backwash ileitis and should lead to diagnosis of IBDU or Crohn. So next question. 16-year-old boy with low-risk ileal Crohn disease achieved remission with corticosteroid and was maintained in oral methotrexate. He now presents with mild abdominal pain and elevated FCAL 620. He's afebrile, growing well, has no red flag feature, stool culture and C. diff are negative. What is the most appropriate next step? Escalate directly to anti-TNF, repeat FCAL in 4 weeks before acting, re-induce remission with steroid or EN and reassess maintenance, switch from methotrexate to azathioprine immediately, begin vedolizumab and taper azathioprine. So half of you have got it right. So when we talk about low risk or mild Crohn disease, the ECHO recommend reinduction. So we will give him another chance of reinduction with steroid or EN before escalating to biologic. So this approach to avoid overtreatment for uncomplicated patient and allow reassessment of maintenance strategy. So what is low-risk Crohn disease? So B1 is when he has a phenotypic B1 inflammatory. So this is the importance of Baris. If you are now by now familiar with Baris, you will know what is low risk, what is high risk. So if the patient has B1 and he has no growth failure, his disease is not extensive, it's not L3 or L4, there is no deep ulcers, no perianal disease, then this is when we chose to re-induce and we label him as mild or low risk Crohn disease. And as you can see here, this is from the ECO 2021 for approaching Crohn disease patients. If you have a low risk Crohn disease and he has no severe growth delay, we are still talking about low risk. So you will start your induction either by EN or corticosteroid, and we know that EN is our preference. If treatment target reached after 12 weeks and treatment targets, we usually assess it by something we call stride. Uh, I, I, we have no time to talk about it, but for sure I can provide something for you to read about stride. So usually they assess the treatment response by 12 week, which is the short response. And if the patient responded, then this is the time where we go for the maintenance, either methotrexate, thiopurine. And this is, if the patient relapse, you can see here, they go back to the reinduction again. This is why we chose this answer. On the right side, those are the patients who we chose to go for the upfront anti-TNF because they are high risk. So risk stratification, or when we go for an upfront anti-TNF, if you go from down to up, if you have a penetrating disease, this is high risk. If you have a structuring disease, first, if there is pre-stenotic dilatation with obstruction, then you might first consider a bowel resection, then to go for the anti-TNF for the post bowel resection recurrence maintenance. If you have a B1 phenotype but with perianal disease, then this is another indication for upfront anti-TNF. If you have B1 but with extensive disease like L3, L4, then we will go with an upfront anti-TNF. And lastly, if you have a growth delay, this is another indication for anti-TNF. So this is one of the important slides, either in your practice or in exam. So next question, we are halfway there. 14-year-old girl with non-Crohn disease present with tender red nodule on her shin. She also has increased stool frequency and abdominal pain. Which of the following extraintestinal manifestation is more likely to parallel her intestinal disease activity? Uveitis, ankylosing spondylitis, pyoderma, gangreosum, erythema nodosum, primary sclerosing cholangitis. So most of you have got it right. It's erythema nodosum. So erythema nodosum typically flare with active IBD and improve with intestinal disease control. It's in contrast to the other we mentioned. This is a summary of extraintestinal manifestation that typically mirror the disease activity. The erythema nodosum, episcleritis, ophthalmomatitis, and peripheral arthritis. On the other hand, the extraintestinal manifestation that's independent of disease activity, primary sclerosing cholangitis, uveitis, ankylosing spondylitis, peripheral arthritis. And this is a common MCQ area, I guess. So the next question, 15-year-old boy with recently diagnosed ulcerative colitis is found to have persistent elevated GGT and mild hepatomegaly. He denies pruritus or jaundice. Labs show normal bilirubin, elevated alkaline phosphatase and GGT, and negative viral serology. MRCP reveal multifocal stricture and bleeding. Which of the following clinical endoscopic feature most commonly associated with BSC IBD compared to classic UC? Left-sided, rectal sparing, normal liver enzyme, continuous colitis. So half of you have got it right. So this is a very important slide. I tried to summarize all the feature of primary sclerosing cholangitis in IBD. So it's a distinct phenotype. Usually it's present with pancolitis, with rectal sparing, but unlike UC, it's more prominent in the right side rather than the left, while UC it's more worse distally rather than proximally. So it's right-sided. Usually it doesn't correlate with the symptom. So you can have normal bucci or mildly elevated bucci. However, it's correlated very well with the fecal calpro. That's why it's when we diagnose the patient with BSC IBD, we usually depend on the with the labs. It is associated with backwash ileitis, as we said before. There is increase of colorectal neoplasia, especially in young male. That's why we will come to the screening in such patients, or screening when to repeat the colon or colonoscopy in pediatric IBD patients. Elevated alkaline phosphatase and GGT may precede clinical symptom. That's why it's important to keep an eye on those blood work every time you ask the patient to come in. It's also associated with the high anti-VR3, as we said before. And strangely, there is a unique feature. I have only seen 2 patients with this feature. It's pseudofiliform changes. When you do an endoscopy, you are still in the colon and you will find a villi. It's like a pseudofiliform changes. You can see it macroscopically and microscopically. So it's not very clear in the picture, but we are in the colon and it was the look was you are in the TI. And again, as we said before, one of the important marker is anti-BR3. It's present in up to 70% of patients. When we diagnose a patient with BSC, it's important to know how to manage them, how to follow them, and how to screen them. They are at risk of colon cancer. And we don't have time to go over the treatment, but usually they find that vancomycin is effective in those patients. So a 7-year-old with ulcerative colitis require 5-ASA therapy, but is unable to swallow tablet. Which of the following option is most appropriate? Mesalamine tablet crushed and mixed with juice, sulfasalazine liquid formulation, mesalamine suppositories only, mesalamine intravenous infusion. Yeah, you are right. So the first answer, we cannot crush the mesalamine tablet because it has the granules. Once you crush it, it won't work. Mesalamine suppository, it's only limited to the distal colon, and we don't have mesalamine intravenous infusion. So 5-ASA is not available as liquid. Sulfasalazine, which contain the 5-ASA linked to the sulfapyridine with the azo bond, and comes in liquid form and is often used in young children with colonic disease. And fortunately now they have commercialized the 5-ASA granules, which is there is bentaza granules, there is azacol granules for those who cannot swallow. So just a little bit of background of 5-ASA. It works on the cyclooxygenase and the phospholipase. It's another drug, or one of the historic drug that we know is aspirin. It has the same principle. It's blocking the cyclooxygenase. By blocking the cyclooxygenase, you will decrease the prostaglandin and leukotrienes. That's in turn will decrease the vasodilation and inflammation. And usually, when you talk about 5-ASA, you will get confused about the pH dependent or time dependent. It's all a concept of where this drug is released. And we can see the green and yellow, they have also commercialized the enema and the suppositories. So we have all kind of drug delivery mechanism. But what I find important in practice is determine the total target dose. And this is the dose that has been studied in the biggest 5-ASA population. It was Protect. And they found that using 75 milligram per kg per day. And the concept number two is the when you calculate the dose, choose formulation that deliver it in fewest tablets possible. So with time and with experience with those patients, we find that those who are on TID, they have worse adherence to the medication compared to those on on BID or OD, even OD. So the message is to go with the nearest calculated dose and to go with the fewest possible tablets. So I tried to summarize what is in the Saudi market, going from the lowest available dose into the highest. So you can have it as a reference, and the green represents the sachet formula, because we deal for the most part with the pediatric population. So yeah, I find it very helpful if you want to screenshot this slide. Don't know. Did we pass the question or not? So next question, a 13-year-old boy with newly diagnosed UC developed worsening diarrhea, abdominal pain, and low-grade fever within 2 weeks of starting oral mesalamine. Infectious stool studies are negative and inflammatory markers are unchanged from baseline. According to ECOS begin, which of the following is the most likely explanation? Acute severe UC flare due to disease progression, corticosteroid-induced colitis, mesalamine overdose, C. diff infection, 5-ASA-induced intolerance reaction. So yeah, you got it right. So you should be familiar with 5-ASA intolerance or mesalamine intolerance. Especially for those who are newly diagnosed and start to flare just few weeks after starting 5-ASA, and you can not explain it by infection, and there is no rising or change in the inflammatory marker. So this usually they blame the 5-ASA, and if you can see the newest acute severe ulcerative colitis guideline, one of the first step they tell you to stop the 5-ASA. So ECOS begin notes that 5-ASA intolerance may mimic an IBD flare with symptoms such as diarrhea, abdominal pain, fever, and occasional blood stool, usually occurring within days to weeks after drug initiation. The key diagnostic clue are negative stool studies, lack of biochemical evidence of flare, symptoms resolve within days of cessation. And you can challenge, of course. You can challenge, and if he flare again, this is like 100%. Uh, uh, now you are sure for like 100%. So this is another practical slide. I have highlighted what is important. As we said before, minimize pill burden. OD dosing is better than multiple or frequent dose. The MMX mesalazine, this is like a matrix, something that allow extended release, which allow a once daily dose. And one of the example is Mesavent. We use it usually for the distal IBD. And you can know they have the macrogranule formulation. And optimized topical therapy, like for distal colitis, you can use the topical therapy, and they have found that if you use combined BO and topical therapy, the outcome is better for controlling the disease. I don't know if we have missed anything else. Yeah, I guess this is the important. So next question, 9-year-old boy with UC started on azathioprine for steroid-sparing maintenance. Which of the following test is most essential to guide dosing and risk stratification before or during therapy? HLA-B27 typing, serum IgG level, fecal calprotectin, TBMT genotyping. Excellent. So the concept with starting a patient on azathioprine is start low, don't start the full dose, and send the TBMT genotype. And once you have the result back, you can go for the full dose. You don't want to end up with a hetero or homo TBMT deficiency. So testing TBMT not 15 before starting thioprine help predict the risk of myelosuppression and allow for dose adjustment. This is critical in pediatric patients to avoid serious adverse events like leukopenia. So this is a basic important slide of the azathioprine metabolism. So azathioprine is converted to 6-mercaptopurine, and if you can see, I highlighted this circulated with green because we usually aim for high 6 TGN, but with monitoring because it can cause hepatitis, and we don't want the 6 mmB because it has nothing to do with the drug efficacy in terms of controlling the disease, and it has the side effects. So this is another figure. It shows in the left side the 6 TGN and 6 mmB, and the therapeutic level. You can see it's lower in the 6 TGN. The cutoff therapeutic level from 235 to 450. We want to be within this range, and we aim for the highest range. We find better control of disease with the higher range. However, with the 6 mmB, you can find it can reach up to 5,700, and the toxicity if you go beyond that. And also, I found the table on the right very important and a common MCQ topic. You should be familiar with how to interpret and react to the azathioprine metabolite in terms of 6 TGN and 6 mmB. So if you have high 6 TGN and low 6 mmB, the adverse event is leukopenia. And if you have the result back of the TBNT genotype, and if you have a homozygous, you cannot continue on the medication. But if you have a heterozygous, you can reduce by half. The second concept, if you have low 6 TGN and high 6 mmB, there is a risk of hepatotoxicity. This is the time when we consider alloprinol and reduce the dose by 30%. If you have both level are low, then check compliance. And if both level are high, there is a risk of leukopenia and hepatotoxicity, so overdose and change or reduce. So I want you also to take a screenshot for, I hope you took a screenshot for this one because it's very important. Also for this one, just as a concept, there is a dose independent, which we called idiosyncratic, like pancreatitis. It's very rare, but if you have it, then the message is don't resume the medication and you have to discontinue the medication. However, if you have a dose-dependent adverse event like leukopenia, then you have a chance to go back to the medication once once his white BC normalize. So the pairs here, thiopurine, are for maintenance, not induction. Pre-treatment genetic testing is essential. If ABV naive, avoid where possible, especially with young male, consider methotrexate as the safer immune modulator. And most of the North American practice now, they don't use azathioprine anymore, although the SBGAN and European guideline still endorse it, but because of the risk of lymphoma, they start to avoid it in North American practice. When to discontinue. So we say it like with idiosyncratic side effects, you have to discontinue the medication. Vaccination and immune modulator. This is a hot topic, and we will go through it in another slide. You have to start the patient on sun protection measures with all immune modulator like thiopurine or methotrexate. Also, there is a lot of debate about combo therapy, exit, proactive monitoring. These are all a hot topic. But what I want you to know that adalimumab combo are not generally recommended. So this is from the latest GBGN 2025, the duration of azathioprine use as a maintenance or as a steroid dependent UC. At least we can use it up to 18 months. However, if it's a combination, then usually we don't go beyond 12 months. And finally, we already said it has nothing to do with adalimumab because the immunogenicity is not as high as infliximab. So thiobrorin and cancer risk, the most common type is lymphoma, including the extremely rare but devastating hepatosplenic T-cell lymphoma, which occur predominantly in young male, and non-melanoma skin cancer. The increased risk doesn't appear to persist after discontinuation of therapy. There are concerns that a primary infection with Epstein-Barr virus during thiopurine therapy increased the risk for HLH and lymphoma. Even though it's important, there is no guideline to test for EBV status before commencing thiopurine. My phone will run out of battery and I'm connected to it. If you allow me, I'll be back. Sorry, guys. So next question. A 12-year-old boy with newly diagnosed UC presents with increased stool frequency, mild abdominal pain, and elevated CRP. Currently on oral mesalamine, the team is considering escalation to systemic steroid or biologic. What is the most appropriate next step before major treatment modification? Start treatment based on symptom and labs, perform fecal calibro test only, repeat colonoscopy to assess disease extent and activity, begin steroid empirically, then scope if no response. Yeah, you are right. So before making a major modification, we have to do a colonoscopy. According to the latest guideline, endoscopic evaluation is recommended before major treatment modification or when it's unclear if symptoms are IBD related. Colonoscopy is also indicated at diagnosis and for cancer surveillance. This ensures that the therapy escalation is appropriate and targeted. So I tried to summarize when to consider doing a colonoscopy. So we usually do it in UC, whether it's associated with primary sclerosing cholangitis or with no primary sclerosing cholangitis. So if you have a patient with UC and he has the disease for 8 years and now he's more than 12, then this is the time to do the CRC surveillance. And some guidelines say it, if it's has been 10 years since the diagnosis, then you have to do that 10 years anniversary for the screening. However, if he has BSC, So once he reached 12, then it's regardless of the UC duration, and afterward it should be every yearly. If he has high CRC risk, like positive family history, very early onset IBD, then it's individualized. If there is high risk, then yearly, intermediate every 3 years, or low every 5 years. If you happen to find dysplasia, which is rare in pediatric, then upon diagnosis, the hepatobiliary cancer, this is some are suggesting doing routine MRCP. I'm sorry, routine MRCP is not recommended in children. So next question, a 13-year-old girl with non-UC present with worsening bloody diarrhea and abdominal pain despite adherence to infliximab. Labs show anemia, elevated CRP, stool testing reveals C. diff. Which of the following is the most appropriate initial management? Start high-dose oral metronidazole for 14 days, initiate Vanco for 10 to 14 days, add corticosteroid for presumed IBD flare, perform fecal microbiota transplantation, stop infliximab immediately. So yeah, the debate between Vanco and Metro, and both are right, but the first line is vancomycin. So these are some bills of C. diff in pediatric IBD because it's a common infection. It can reach up to 47 and causes flaring. Risk factor for severe exacerbation and hospitalization. Incidence of hospitalization, it can increase to 70 times higher than non-IBD beers, and it leads to longer hospital stay, higher colectomy rate, and mortality. So indistinguishable from IBD relapse, C. diff must be excluded before changing IBD therapies. 14-year-old boy with acute severe colitis has received 3 days of IV corticosteroid without improvement. Which of the following is the next best diagnostic step to exclude CMV colitis? Yes, you are right. So most of you have got it right. And this is in the old and latest guideline of acute severe ulcerative colitis. By day 3, if you have no response, it's the time to do the sigmoidoscopy for CMV. And CMV diagnosis, the PCR alone is not sufficient. Positive PCR in the absence of inclusion bodies or positive staining is insufficient for diagnosis of CMV, since PCR lacks specificity for a clinical meaningful infection. CMV treatment, IV ganciclovir. You can switch to oral valganciclovir if improved. So here's the latest ECHO guideline. It was published just recently, a few months back. And if you can see, by day 3, I have highlighted the sigmoidoscopy. If CMV positive, start treatment. So by day 3, if the bucci is still didn't drop by more than 20, then it's the time to start your pre-biologic workup, including the surgeon, and check that all the baseline investigation has been done, and repeat the ultrasound, and repeat blood, and do the sigmoidoscopy. A 14-year-old boy is admitted with acute severe ulcerative colitis. He's on IV corticosteroid. The team is concerned about giving low molecular weight heparin prophylaxis due to the risk of gastrointestinal bleeding. Which of the following is the most accurate statement? Low molecular weight heparin should be avoided in acute severe colitis because GI bleeding risk. Low molecular weight prophylaxis is only given if the patient requires surgery. Should be given as it doesn't increase IBD related GI bleeding risk. Mechanical, it's a long. So let's see what you answered. Should be given. Okay, this is correct. So this is also a new change in the 2025 guideline. Let's read it again. Low molecular weight heparin prophylaxis should be given as it doesn't increase IBD-related GI bleeding risk. Acute severe colitis increases the venous thromboembolism risk. Especially we are using steroid, there is severe inflammation, central line, immobility. These are all a risk factor for the venous thromboembolism. Pediatric cases are rare, but risk is significant and potentially life-threatening. Pharmacological prophylaxis, usually low molecular weight heparin, should be considered in adolescents with acute severe colitis, especially with additional risk factor. Maintain high clinical suspicion. Venous thromboembolism in IBD often present atypically, like limb swelling, chest pain, or neurological sign. So you can just capture screen this slide because it has the risk factor and contraindication. If you go in some guidelines, if he has one or two risk factor, then you will go for the BID dose. If he has no risk factor, then you might only use OD dose. But know for sure the contraindication is inherited or acquired bleeding disorder, if he has thrombocytopenia, coagulopathy, or surgery in the past for coming 24 hours. And in the left, there is an outpatient and inpatient approach. So for the sake of time as well, I have attached one protocol here from a North American hospital for pediatric children, and these are actually the prophylaxis different from where you are practicing and what is the policies there. So a 13-year-old boy with newly diagnosed left-sided ulcerative colitis is started in oral mesalamine 60 milligram per kg per day and rectal 5-ASA. After 10 days, his Bukai score has improved by only 10. He remains symptomatic with 4 to 5 bloody stool. What is the most appropriate next step? Continue current therapy and reassess after 4 weeks. Add oral corticosteroid. Increase mesalamine dose to maximum 4.8, which is the maximum. Start thiopirin for steroid-sparing maintenance. So you are right. So we don't have, as we said, we should have more than 20 drop in Bukai. Drop less than 20, decrease in Bukai after 7 to 14 days of treatment is considered lack of response. So we will call it like refractory. Requiring treatment escalation. Initial therapy include oral plus minus rectal 5-ASA. If response is inadequate, oral corticosteroid are added. Thiopirin are not used for induction, they are for maintenance, typically after steroid dependence or failure. So I guess these are a set of steroid and IBD because it's important. So 12-year-old boy with pancolitis is admitted for acute severe ulcerative colitis, started on IV methylpred 1 milligram per kg per day. On day 4, his Bukai remains 70 with no clinical improvement. How should this patient be classified? Steroid responsive, steroid dependent, refractory, or intolerant. So most of you have got it right. So in acute severe ulcerative colitis, failure to improve after 3 to 5 days of IV corticosteroid, now we can call him steroid refractory. This is the key decision point to escalate to riscotherapy. So these are the different category of steroid use in IBD, either steroid responsive, refractory, or dependent. And each has its own definition. So responsive, if there is clinical remission after induction, Bucay less than 10. The steroid refractory is failure to respond to adequate steroid therapy, and dependent is inability to discontinue steroid within 3 months or relapse within 3 months of stopping. And you can take screenshots to go further in this slide. So this is also from the latest guideline. We have gone through part of it, but we always come to the question in the left, like, what if there is prior oral failure of the steroid? Would you still consider giving IV methylpred? What if is there a difference? What is the recommendation? Should we give an OD or BID dose? And for the refractory cases, what to do? Which corticosteroid? Should we go for IV methylpred, hydrocortisone, dexamethasone, the standard dose, which is 1 milligram per kg per day, versus the high dose, like reaching 60 milligram per kg per day, or does pulse steroid work? And those who respond to a higher dose, and when to switch from IV methylpred to oral steroid. We consider it as weaning. It's a weaning. Even if we continue in the same dose, like 40 milligram IV, and you switch it to 40 milligram oral, this is weaning. So to answer this question, IV methylpred 1 milligram per kg, maximum 40 once daily is the first line. Higher doses, only in UC, acute severe ulcerative colitis, we can go up to 60 milligram. And there is no rule in Crohn's disease. We don't go beyond 40. Do not extend IV corticosteroid beyond 7 to 10 days. There is no added benefit and there is risk of toxicity. If contraindicated, like uncontrolled diabetes or those with behavioral changes, you don't want to consider steroid on them. If started on high dose, reduced to 1 milligram per kg per dose, maximum 40 once, response observed. So if let's say you went to the 60 milligram, don't stay on the 60 milligram for a long time. Try to went to 40 as patient is improving. There is no tapering needed if IV corticosteroid is used for less than 10 days, and moving to riscotherapy if longer or repeated steroid exposure, consider rapid taper to physiological dose, which is prednisolone 0.2 milligram per kg per day, maximum 20, then slow withdrawal to avoid the adrenal insufficiency. We prefer once daily morning doses to mimic the physiological pattern and to reduce risk of adrenal suppression. And during my practice, I found that we go only to BID dose if we find that the patient has a high buccal that's driven by the night symptom. So if the night symptom is what's making the buccal high, we might go for the BID dose. But overall, we go only for the OD dose. The oral steroid failure before admission should not preclude IV corticosteroid, as up to 80% still respond. So I hope we answer most of the question. So a 12-year-old boy with steroid refractory acute severe ulcerative colitis is planned for infliximab rescue. As part of pre-biologic workup, you'll find varicella negative, IgG negative. He's non-immune. He's still symptomatic with Bucay 70. What is the most appropriate management of varicella immunity in this context? Delay infliximab and administer live attenuated varicella vaccine immediately. Proceed with infliximab, advise family to avoid exposure and plan varicella vaccine after immunosuppression is stopped. Administer varicella zoster immunoglobulin now, then start infliximab once seroconversion occur. Proceed with infliximab if exposure occur later. Use post-exposure prophylaxis. So there is some debate between C and D, and the correct answer is D. So usually if patient is sick and high buccal and you are considering starting the biologic, don't wait for the seroconversion or to deal with the varicella issue now. Because we are stuck, we have to start it. And once we start the varicella, we have to wait for like more than 1 month. Some say 6 weeks to after live vaccine to start the biologic. So in urgent acute severe ulcerative colitis, biologic rescue cannot be delayed for vaccination. Live vaccine are contraindicated during immunosuppression. If a child is non-immune and exposed while on biologic, immediate post-exposure prophylaxis is required. Families should be counseled on avoidance of exposure and informed of the risk management plan. So in elective setting, you are not in rush to start it, then this is the time to plan for the live attenuated varicella vaccine, and it should be given before immunosuppression. And the minimum interval is to wait for 4 weeks after live vaccine before starting immunosuppressive therapy. And these are all the bits of the live vaccine and steroid or other IBD therapy. Because of the sake of time, I'll just want you to take a screenshot for that. So a follow-up question. After day 4, he continues to have 9 to 10 bloody stool with Bucay 70, anemia, and low albumin, and no neutrophilic response, even with dose optimization of IV methylpred to 60 milligram. Stool C. diff PCR is negative. Sigmoidoscopy done at day 3 showed deep ulcer with neutrophilic cryptitis, but no CMV colitis. What is the most appropriate next step? So those who haven't answered, we can give you some time. It's a long so maybe it's closed. So you got it right, most of you. Initiate infliximab rescue with intensified induction regimen. And this is the only place that you will see intensified induction. It's usually in acute severe ulcerative colitis. So with this patient, the pre-biologic workup, it should has been initiated by day 3 latest. We should have done the TB, hepatitis, varicella, and chest X-ray. And as we said, we will go for the intensified induction. The standard dosing, it's 5 milligram per kg. And it goes like 0 to 6, then 14. But the intensified induction or accelerated even intensified induction, it's 10 milligram per kg or 400 milligram per meter square. And what we do is you calculate both, but whichever is higher, you will choose that. And always round up to the next 100. For example, if your calculation turn up to be 301, then go for 400. Usually we like more drug than less. And this is the standard regimen is 5 milligram per kg or 200 milligram per meter square. Standard is 0 to 6. While the accelerated is 0, 5, and 28 days. So he will receive all the doses within the first month. And this is a study in those who has steroid refractory acute severe ulcerative colitis. And you can see the intensification of infliximab induction was associated with higher response rates in the steroid refractory. This is the intensified patient clinical response as we can reach, it can reach up to 90. While in steroid dependent, intensification of the dose didn't really matter or make difference in the response. So usually with steroid refractory acute severe ulcerative colitis, we will go for the intensified induction. So a little bit of background on anti-TNF and advanced biologic. I don't know if we can continue, Dr. Mohanad.
إلا تفضل دكتور، تفضل راحتك.
طيب. So the potential pharmacological therapy for pediatric IBD. So previously we have the concept of the conventional therapies, what we know as non-targeted small molecules like corticosteroid, mesalazine, immunosuppressant, or antibiotic. But now the new era is the advanced therapy, targeted biologic like anti-TNF, anti-integrin, interleukin 12, 23, or even now the hot topic in the adult world is the JAKs inhibitor. So if you can see here, this is the FDA approved IBD in adults. And if you look in the right side, you can see the explosion of the medication approved for IBD in adult world. However, if you compare it to the pediatric, it's not that much. We don't have much approved medication, given that it's harder for the pediatric population to get approval. It's harder to have them entered an off-label medication trial, even though the disease behavioral and the phenotype in the pediatric population is more aggressive, but we still behind in term of approved or FDA approved medication. But the good news is Stelara, which is secukinumab, has been now finished the phase 3 trial, and we soon expect it to be approved. We can use it for those from 2 years old and older. So again, infliximab standard dosing is 5 milligram per kg per dose. The induction is 0 to 6. Then we will go every 8 weeks. So a little bit of background. This is how the TNF anti-TNF looks like. This is the FC portion where it binds to the receptor, and it has the heavy chain and the light chain. And if you can see here the difference between the infliximab and adalimumab. Adalimumab is mostly from human, while infliximab has murine parts, which is from mice, and this is why it has more immunogenicity, and this can explain why we use combo therapy with infliximab more than adalimumab. So I don't know if we can go through it, but at least take picture. This is the differences between infliximab and adalimumab. And this cartoon, it showed a really nice depiction of the how the cells looks like. So this is the TNF receptor, and when the inflammation started, the inflammatory cell started to bind to the TNF receptor to start the cycle of the prokinetic and pro-inflammatory process and inflammation. And if you can see here, this is the anti-TNF. I mean, this is the TNF. And the anti-TNF, it's usually block the receptor to prevent the circulating inflammatory TNF from binding to its receptor. So this is how we prevent or how the anti-TNF works. So this is a cartoonic summary of other mechanism. So we have already spoke about the anti-TNF agent. We have the anti-interleukin 12 and 23. And the most used one is the ustekinumab, and risankizumab is used now, especially for those with psoriasis. The anti-integrin is the one which considered most safe because it's gut specific, like vedolizumab, and a lot of data have supported using it in pediatric, especially pediatric UC. And we have the new JAKs or JAK inhibitor like tofacitinib and obasitinib, and it's really will shift the how we see the biologic medication in terms of how we take the medication. It's oral, so the adherence will be better. And a lot of data have showed that the steroids, it has been used less and less on those patients, steroid sparing as a steroid sparing agent, and it has a lot of good mucosal healing data. But the pitfall that it can cause cardiac issue, lipid issue, so I don't think it will be approved anytime soon. So this is the interleukin 12 and 23. You can see ustekinumab and risanikizumab. They share the same B40, but they are different in the B35 and B19. And in terms of safety, you can see for sure in the top of the pyramid, it's the nutrition for sure. And after that, Vido comes, vedolizumab, because we know it's gut specific. So it doesn't have systemic involvement. And at the bottom of the pyramid, it's always steroid. So this is published recently. So a lot of important concepts like positioning and sequencing, steroid, dual biologic. And we have went through this slide before. So I guess we have three more questions to go. So your 12-year-old boy with steroid refractory acute severe ulcerative colitis on infliximab and steroid induction at week 6, he worsened again with Bukai 65. TDM show infliximab trough very low, but no anti-drug antibodies. How should this loss of response best be classified? BK failure, BD failure, primary non-response intolerance. So there is a lot of discrepancy and debates. So it's an important concept to differentiate between pharmacokinetic failure, pharmacodynamic failure, primary non-response, secondary non-response, and intolerance. So the correct answer is pharmacokinetic failure. So BK failure or pharmacokinetic is when you have low drug and no anti-drug antibodies. It's because rapid clearance. It's usually common in acute severe ulcerative colitis because there is a lot of circulating TNF alpha and high inflammatory burden. So when you give the anti-TNF, it will be sucked up by the major inflammation. So that's why they came with the concept of dose intensification and accelerated induction. The BD failure, it means adequate therapeutic drug level, but inflammation persists, disease not responsive to drug mechanism. And usually when we have BD failure, usually we consider switching to another biologic. And usually it will be like out of class. If it's like infliximab, we will not choose adalimumab, we will choose something else. Primary non-response means no benefit during induction. Secondary non-response means patient has been responding for a while, then start to lose the response. Intolerance means if the patient develop reaction, some develop nasty psoriasis. That's why we have to stop the medication. So next question. 16-year-old female with Crohn's disease was in remission on infliximab for 18 months, but now present with worsening abdominal pain and elevated CRP. Her infliximab trough level is low. Anti-drug antibodies are present at high titer. What is the most appropriate next step? Escalate infliximab dose and monitor, add azathioprine and repeat drug level, switch to adalimumab, switch to Vido. So this is a different way to interpret the TDM. Now you have low drug level but positive anti-drug antibodies, and it is high. So you are right, we will switch, but within the class. The first clue is if you see a patient that has been responding to infliximab for a while, for a long time, then you will consider keeping the patient on the same category before giving up on the anti-TNF. So this is a secondary loss of response with high anti-drug antibodies titer. The high titer antibodies neutralize the drug and reduce efficacy. Dose escalation won't work. The best approach is to switch to another anti-TNF, so within the class. And vedolizumab is an out-of-class biologic used when trough level are therapeutic but ineffective. Like if the patient has BD failure, this is the time when we go out of class. Adding azathioprine may help with the low titer antibodies, but not in this high titer setting. So this is the best slide to summarize how to approach to a TDM with antibodies. So first, you have to look to the TDM if it's within range and the patient is symptomatic. Then this is a pharmacodynamic failure or BD failure. And since there is no response with good drug level, then you have to switch out of the class, out of class. However, if the TDM is low, then you have to look for the anti-drug antibodies. If there is no anti-drug antibodies, then this is a pharmacokinetic failure, and you have to escalate or optimize the dose. And if there is high anti-drug antibodies or positive anti-drug antibodies, then you will see if it's high or low. If it's high anti-drug antibodies, then switch from infliximab to adalimumab as our previous question. But if it's low anti-drug antibodies, then you can escalate or add immune modulator. And I have come to know from your colleagues that a lot of MCQ come from this slide. So this summarize all the different bits. So this is from GBGN. It showed the concept of proactive and reactive. So reactive means per se, you will do the TDM if the patient is symptomatic. But proactive, it's planned, scheduled TDM, which proven to be more effective, and we will increase the drug durability. We will prevent the anti-drug antibodies if we adapt this approach. And this is suggested therapeutic drug monitoring target. You can take a capture screen of it. For infliximab, adalimumab, Vido, and for perianal fistula, we usually like higher level. So in my practice, we usually do the TDM before an induction, before the third and fourth dose. Before third, we like it to be more than 25, and before the fourth, we like it usually to be more than 20. And it depends upon the phenotype of the disease. Usually with perianal disease, we like higher anti-TNF. Usually, once the patient reach a steady state, we usually do the TDM every 3 cycles. So this is an important slide to differentiate between reactive and proactive. So reactive mean performed after symptom or loss of response, while proactive performed at scheduled interval regardless of symptoms. Timing during flare or suspected loss of response, while the proactive at defined time points like 2, 6, 14, etc. The advantage of reactive, it can explain loss of response, PK versus BD, and guide immediate management. while proactive, which what we are advocate for now, is prevent relapse, reduce immunogenicity and hospitalization, and it's cost effective. Limitation, delayed after patient worsen may miss prevention window, while proactive, more lab utilization, risk over treatment if not interpreted well. And you have here a clinical example. So in summary, proactive TDM can improve steroid refractory and reduce incidence of high titer anti-drug antibodies and reduce anti-TNF cessation related to anti-drug antibodies. So I guess this is final question. So a 14-year-old boy with extensive UC has failed infliximab despite dose optimization. You are considering the next biologic. Which of the following agents showed the highest rate of steroid-free remission and endoscopic improvement after anti-TNF failure? So what would you choose after anti-TNF failure in extensive UC? So the correct answer is ustekinumab. And I'll tell you why. Usually, if you go for vedolizumab as in biologic naive, the outcome will be perfect. But studies showed that if you use vedolizumab after anti-TNF failure, the data showed it's not that beneficial. I don't know why we got stuck. There is no more slides. Okay, Reem, mashallah. But we have one more slide, I guess. We can go back to this. So to continue, why ustekinumab following anti-TNF failure in pediatric UC? If you can see here, prior anti-TNF, the steroid-free remission can reach up to 70%, while prior anti-TNF failure and vedolizumab, it's go down to 17%. That's why they suggest to go for ustekinumab as second line after failing of anti-TNF. Because if you consider it as third line, there is a steep or huge drop in the response rate. And while if you consider vedolizumab, usually consider it as first line in steroid dependent. So the sequencing of biologic in pediatric UC, infliximab or vedolizumab as first therapy for steroid-dependent UC. As for the anti-TNF failure, in our question, ustekinumab is the first one before Vedo. And this is the era of Jackie, Uba, and Tufa for refractory patients. And I want you to take this slide to take a picture because it summarizes most of the conventional and biologic and its uses in different domain like induction, maintenance, what to use in perianal disease, what to use in peripheral arthropathy, what to use in axial, what to use in pregnancy, etc. So to go back and congratulate Reem, Hamad, Abdulaziz, mashallah. All of you have done good, mashallah. This is my contact info. I know it has been a heavy session, but I hope you got benefit. Thank you.
شكرا جزيلا دكتور إياد، صراحة جدا جدا رائع، واستفدنا ونفع بعلمك مرة مرة رائع. think you covered the most important part of the IBD. I think all the parts of the IBD, clinical tips, exam oriented. فجزاك الله خير مرة. أنا استمتعت جدا جدا بالبرزنتيشن. ويعطيك
اللهم
ألف عافية دكتور إياد.
بالتوفيق إن شاء
وشكرا لك.
الله. الله
الله
يوفقك.
يعافيك. كويس إنه إحنا سجلنا المحاضرة، لأنها أعتقد حتكون منهج للآي بي دي قبل الاختبار، فرائعة جدا.
الله
فجزاكم
يجزاك.
الله خير كلكم على حضوركم، وشكرا مرة ثانية دكتور إياد، والله يكتب أجرك على هذا الموضوع الرائع.
الله يوفقكم. شكرا دكتور مهند، أنا راح صوتي.
الله يعطيك العافية، تسلم.
شكرا شكرا.
يلا نراكم بإذن الله إن شاء الله غدا نفس التوقيت. يلا مع السلامة.
شكرا، مع السلامة.